Assalamu alaikum. Welcome all of you. Can you hear me? Assalamu alaikum.
Yes, your voice is very clear.
I am Dr. Nida, and I'm for a brief introduction. As you all know me, I'm an assistant professor at DUHS. Welcome all my colleagues, seniors and juniors, the speaker, and thank you, Barrett Hodgson. We should start our program with the name of Almighty Allah. As you know that थोड़ा सा प्रोग्राम के बारे में डिस्क्रिप्शन बताऊंगी, लेकिन पहले हम तलावत से स्टार्ट करते हैं एंड देन वी प्रोसीड फॉर द प्रोग्राम. नासिर प्लीज तलावत लगा दें.
नासिर आवाज नहीं आ रही.
जरीन, आपको आवाज आई है?
No, I can't hear. Maybe एक इशू ये हो कि रिकॉर्डिंग हमें स्टॉप करनी पड़े ड्यूरिंग तलावत, तो जूम की रिकॉर्डिंग को आप पॉज करें और फिर चला के देखें.
वनहर इन्ना शानिअका हुवल अब्तर सदक़ल्लाहुल अज़ीम.
Jazakallah, Dr. Hassan. Thank you very much. So let's begin with the program officially. This is a course the course is having 13 CME credits, and whoever attend all the lectures and will get the certificate in the end of the course after verification of the registration. So registration is mandatory for the CME credit hours. Special thanks to the director of NIDE, Dr. Ali Baloch, and the whole faculty of NIDE, especially Dr. Zareen, Dr. Hassan, and to Barrett Hodgson. And first of all, I would like to introduce my speaker, who we are privileged of having Dr. Tasnim Ahsan, who is an endocrinologist and internist, graduate of Dow Medical College 1978. And she completed her postgraduate training in UK and done MRCP. And she was still associated with Jinnah Postgraduate Medical Center, retired from JPMC on 2015 as an executive director, professor and head of department of medicine. हमारे पास बहुत अच्छी आज opportunity है that she is having she has given time for us, और हमें बहुत अच्छा लेक्चर अभी क्या कहते हैं वो डिलीवर करेंगी regarding the interpretation of thyroid test. So लेकिन उससे पहले before delivering the lecture, we have some pre-lecture MCQs which has been made by Dr. Zareen. So I would like Dr. Zareen के अगर वो MCQs start करवा दें, and then we will proceed to Dr. Tasnim Ahsan for her lecture.
Let me correct, Nita. The questions have been prepared by Professor Tasnim herself.
Okay,
and
I'm sorry.
जी. Let me share the poll. I think poll में launch कर रही हूँ और एक question को फिर I will just read them out quickly ताकि हमारे पास polling answers जमा हो जाएं. So I will not disclose the answers now, and answers will be discussed at the end of the lecture. So this is the first question, which is 25-year-old female with gestational amenorrhea of 7 weeks. Presents with palpitations and excessive vomiting for 10 days. On examination, there is a grade 2 goiter. Her thyroid function tests are that TSH is 0.1, free T4 is 1.9, and what is the likely diagnosis? So I would like to request the attendees to start opting the answer now. The option 1 is Graves' disease, option B is thyroiditis, C is toxic adenoma, D is drug-induced hyperthyroidism, and E is gestational thyrotoxicosis. Once you will opt this question, and then I will move on to the next. So please start polling now so that we can gather some percentages.
I think we
Nasi
have
sahab,
5 to
can
7 minutes for this BCQs.
Are the attendees able to opt for the choice? Okay. Thank you, Binish Masood. You have answered. Thank you very much. So we've got 100% answer for question 1. Let's move on to the second question. A 70-year-old man was admitted to the ICU with features of septicemia due to community-acquired pneumonia. Which one of the following is a typical pattern of thyroid dysfunction seen in situ thyroid illness? So option A is increased T3 and T4 and decreased reverse T3. Option B is increased T3, T4 and reverse T3. Option C is decreased T3 and T4 and increased reverse T3. Option D is decreased T3 and T4, normal reverse T3. And option E is decreased T3 and T4 and reverse T3. So there is an answer for that. Option C has been marked by most of them. Let's move on to the next question. Which of the following form is the most active form of thyroid hormone? And again, there are 5 options. Option A is T3. Option B is T4. Option C is reverse T3. Option D is both T3 and T4. And option E is free T3. So we have a good polling response for this. And people are still opting out. So 40% answer for A and 40% for E. I wonder if more people are participating. So option E is gaining popularity now. 50% have answered for that. I would like more attendees to kindly participate in the poll. This is good for you to learn because by the end of the lecture, this will be repeated. So we'll get to know whether you were correct or not. Okay, I'll move on to the next question now. Sorry. Question number 4 is 70-year-old lady. A 70-year-old girl was incidentally detected to have abnormal thyroid function test. She had a family history of thyroid dysfunction. On examination, she had mild tremors and pulse was 76 beats per minute. Her free T4 is 2.4, free T3 is 7.8, TSH is 7.2. And what is the diagnosis? Option A is pregnancy. Option B is prolactinoma. Option C is subclinical hyperthyroidism. Option D is subclinical hypothyroidism. And option E is thyroid hormone resistance. So 50% of the participants have opted for option E. Last question. 40-year-old male presented with low mood and weight gain. He is taking amlodipine, rosuvastatin, olanzapine, and lithium for his medical conditions. His labs are TSH is 9, T4 is 10, and T3 is 3. So what is the most likely diagnosis? Thyroid hormone resistance or drug-induced subclinical hypothyroidism, which has been opted by 83% of the participants, SA interference, recovery phase of nonthyroid illness, and TSH secreting pituitary adenoma. So I assume most of you who wanted to participate have already done so. So let's just end the poll now. Okay, people are still opting out. As you can see the timer, it is showing 5:44, 46, 47. So after 6 minutes exact, I will end the poll. Okay, I think this is more than 6 minutes now. So I will just end the poll and over to you, Nida.
Thank you very much, Dr. Zareen. Now I request Madam Dr. Professor Tasnim Ahsan, a very long list of her achievements, and I pardon if I have forgot anything, but now she is associated with MIDEM, which is another institute in a private sector, 2017, and it is purpose to deliver multidisciplinary standard of care therapy to patients. Trained professionals undertake research and engage in preventive medicine ventures. Madam, please kindly start the lecture. And the lecture is on interpretation of thyroid function test. Over to you, Madam.
Can you see my screen?
Yeah, no, we are not. We are able to see you. Yes, we are now able to see your screen.
Assalamu alaikum, everyone. First of all, I would like to thank Dr. Zareen and the faculty of DUHS and NIDE for inviting me to deliver this talk in your course on endocrinology. A very commendable effort. Can you hear me?
Yeah, but it is a little, मतलब थोड़ा जोर से अगर आए मैडम तो अच्छा.
Louder. Okay. So I'll try in the course of next half an hour or so, I will go through the subject that I'm assigned to talk about today. The way I plan to do it is to start with a little bit of introduction and lay down the base, and then go into interpreting different thyroid function tests and looking at the different TFT patterns and how they are formed and what possibilities exist. And then a brief look at some of the anomalous TFTs on people on thyroxine therapy. Then a brief reference to the interference with the assay of these hormones. TSH resistance, though not very common, but every now and then you might come across one, and unless we are mindful of it, we're going to miss it. And a brief word about drugs affecting thyroid hormone secretion, and finally concluding. So before we start, let me talk briefly about the synthesis, storage, release of thyroid hormones. And this is a cartoon of the synthesis of thyroid hormones. So that's the blood vessel from which the iodine is being trapped. This is the follicular cell. That's the lumen of the colloid within the follicle. The first step is the synthesis of thyroglobulin, which is synthesized by the endoplasmic reticulum, and bound thyroglobulin and tyrosine are then discharged into the follicular lumen again. So the iodine is brought here and thyroglobulin is secreted here. And the next step is the oxidation of this iodine. And the next further step is the organification of iodine when it is attached to tyrosine to form diiodotyrosines or monoiodotyrosines like here. And finally, the coupling of iodinated tyrosines to link together to form either T4 or T3. So that is something that we all know, just elementary. But let's go on to the, unless we understand this basis, we cannot go on to understand some of the more difficult problems that we sometimes encounter. So let's look at the tiers of regulation of thyroid hormone secretion in action. The thyroid hormone production is tightly regulated by hypothalamic TRH and pituitary TSH. Cellular entry of thyroid hormone, efflux, and balance of T4 and T3 in many tissues is dependent on specific membrane proteins, the MCT, they're called MCT for short, membrane carboxylate transporters, to be precise. And this the membrane, these proteins transporters allow the thyroid hormone to get into the cell. The next tier of regulation of thyroid hormone action is provided at a pre-receptor level by a family of intracellular deiodinases. So these deiodinases are of different types, and there are different kinds of deiodinases in different tissues. So deiodinase 1 is in the liver, where T4 or T3 is converted, and deiodinase 2 converts T4, T3 in the hypothalamus and pituitary. So the main deiodinase responsible for the negative feedback, and deiodinase 3 converts T4 to reverse T3. So it is a kind of limiting thyroid action kind of deiodination step. Thyroid hormone genes in the nucleus of the cell then constitute the final layer of effect, where again things can go wrong. So thyroid hormone receptor alpha and thyroid hormone receptor beta genes, and these then lead to different effects in different organs depending on how much of these genes or receptors are expressed in which organs. So alpha 1 receptor is in the CNS, myocardium, colon, and skeletal muscle. Alpha receptor concerned mainly with the negative feedback in the hypothalamus and pituitary. These receptors are very important from the point of view of the receptor defects of thyroid dysfunction, which are not very common, but nevertheless, we need to understand this mechanism before we can begin to analyze of the whole situation. We're all familiar with this bit, which is the TRH in the hypothalamus, which has a positive stimulatory effect on the thyrotroph in the pituitary anterior part, and the negative effect is the somatostatin from the hypothalamus as well. So TSH secretion, and then leading to T3, T4, negative feedback. And then again, it shows you that in the hypothalamus, the beta receptors are more than the alpha receptors. And the same applies to the pituitary. But when we go to the organs themselves, we see that every organ has some framework of where one receptor is dominant as compared to the other. And this is what happens at the cellular level. Remember, I talked about membrane carboxylate transporters. They are mainly responsible for transporting the T3 inside the cell. The T4 enters the cell on its own. And once inside the cells, the deiodinases come in, and they then lead to the formation of different compounds, and T3 is finally synthesized as a result of it. And this is within the nucleus, where a co-activator, then a retinoid X receptor is there, and then there is the thyroid receptor. And it is in these receptors that we've been talking about. T3 acts over there to affect DNH synthesis, and this is the thyroid reactive expression over there within the cell as a result of this very complex process. The reason for showing this is that you can well imagine that things can go wrong at any one of these steps. And this is the basis of thyroid resistance syndromes. So having laid down a basis for how these things work, the interpretation of thyroid hormones, let's start looking at the clinical stuff that we encounter. So thyroid function tests. Slide is stuck for some reason. Okay, so let me lay down a few broad guidelines with regards to thyroid function tests. So there are population reference ranges for thyroid hormone, and these are relatively broad. And by the way, we do not have a population reference range for our own population. So we kind of borrow and use those. In contrast to the narrow individual variations of thyroid hormone in normal subjects. So this basically means that the reference range that we see on the report is a population reference range. But for an individual, this reference range is pretty narrow. And that just find. So this reference range for an individual person is pretty narrow. And this lays down the basis for what happens as a consequence of it in the thyroid function test. So modest changes in thyroid hormone are associated with marked excursions in TSH. So if you see a normal T3 and T4, but you see an elevated or a suppressed TSH, that is reflecting that individual person's thyroid hormone status. The changes in thyroid hormone sufficient to render a subject hypo or hyperthyroid may not be associated with numerically abnormal T4 and T3, like we talked about. And this is the basis of the subclinical hypo and hyperthyroidism. So TSH is a frontline screening test for thyroid dysfunction. We all use it, but it may be quite deceptive in some patients, and this can lead to a misdiagnosis if we are not aware of that possibility. So as long as we are talking about primary thyroid disease, TSH alone is a good screening test, but not otherwise. Changes in binding proteins will affect T4 and total T3 levels, and therefore we should not, as a rule of thumb, be doing the total T4 and T3 when we are evaluating thyroid function tests. These are some of the most commonly requested lab investigations, and what is usually written is thyroid profile. So I request all of you who are listening to this talk to refrain from writing a thyroid profile. If you think it is primary thyroid disease, then just order a TSH. And if you think that there might be a secondary possibility, then you do a free T4 and TSH in most conditions. And then in some, you will need a free T3 too. So don't write a thyroid profile. So usually the interpretation of thyroid function test, fortunately, is quite straightforward, but sometimes you have a discordant result. So the negative feedback that we understand doesn't seem to be operative. And what is this discordance? This is either a discordance with the clinical picture. So the patient looks like hyperthyroidism and the TSH looks like hypothyroidism. It's raised, just to give an example. Or the TSH and the thyroid hormones are discordant with each other. So in this situation, what do you do when you see a set of discordant thyroid function tests? Reconsider the clinical picture. That's the first step. Recognize that there's something not quite right. And then you need to consider alterations in normal physiology, which happens at various stages of life or pregnancy and therefore and so forth. And then consider the possibility of a non-thyroid illness changing things, other medicines that are in use and they may be affecting the thyroid function test, laboratory artifacts if nothing else is coming forth, and then of course the rare genetic disorders. So discordance is something that needs to be understood. It requires a clear understanding when you have discordance of the hypothalamic pituitary thyroid axis physiology. It requires thyroid hormone action, understanding at the tissue and at the cellular level, something that I've briefly alluded to previously. And then there is a diverse array of congenital and acquired conditions with different TFT patterns. So, you need to have some knowledge of them. So when you're interpreting thyroid function tests, what are the specific considerations? So you must always remember the clinical context. What is the patient looking like? And then what is the clinical thyroid status? TFT should only be done to evaluate specific features of primary disorder of HPT function. So don't just, if you can't think of anything else, don't just order a thyroid function profile, because the chances are that you will not end up with an answer. So only request when you really think that there is likely to be a disorder there. Thyroid hormone and or TSH estimation when there is a low index of suspicion for HPT dysfunction risks in giving you results that are going to only confound further. Many labs provide a generic reference range for T4, T3, and TSH, and that may not be appropriate, like I said, for our population and ethnicity. It also depends on the state of iodine intake and gender, age, as well as the BMI of the patient. So sometimes all of these factors have to be taken into consideration. Let me go briefly over some of the factors about non-thyroid illness and how they affect interpretation of thyroid function tests. So basically, when we say this is a test which is due to non-thyroid illness, we are saying that there is an absence of intrinsic abnormality of HPT axis. And what you see on the changes you see on the thyroid function are actually a secondary adaptive change. It's another matter that we don't know whether these adaptive changes are to protect life, or in other words, beneficial or detrimental to the clinical situation. That is not known for sure, but these changes do happen. And these changes in thyroid hormone and TSH occur as, particularly T3, occur as early as 24 hours after the onset of a severe non-thyroid illness. So it's an early change. And a decreased total T4 correlates with a less favorable outcome in a severe non-thyroid illness. So that there's a prognostic thing involved here. Reverse T3 is usually elevated. That's the key change. And we don't measure reverse T3 here. So basically look at the T3, which is decreased. Precise mechanism for changes noted in thyroid hormone synthesis and secretion, as well as transport, cellular uptake, and action remain under debate. So they're not clear, but all of these things are affected. And the one thing that we know for sure is that when the patient is in the recovery phase, the thyroid hormone and the TSH return to normal. However, the TSH may take a little bit more time to kind of come back to normal. So another area of human physiology, that female physiology, that has to be remembered, and the key things that we need to remember about pregnancy and thyroid dysfunction or thyroid function tests, is that pregnancy has a significant impact on HPT physiology with marked changes in both thyroid hormone and TSH. So there is increased thyroid binding globulin under the influence of estrogen, and which is because of both increased hepatic synthesis and decreased degradation. There is increased total T4 and total T3, and the increase may be like 150% of the non-pregnant values during the first trimester. Happens pretty early in the first trimester, and then it is kind of maintained through pregnancy. There is a transient increase in free T4 in the first trimester, and this is under the influence of the pregnancy hormones, beta-HCG, which is elevated. Beta-HCG goes down by the end of the first trimester and kind of stabilizes by about 16 weeks, early second trimester. Hyperemesis gravidarum, especially when there is twin pregnancy or triplets and the beta-HCG levels are really high, can actually give rise to overt thyrotoxicosis with a fully suppressed TSH. And HCG decrease in the second trimester and third trimester, like I said, reverts the FT4 to normal or even lower than normal, and TSH levels are restored. So what about misdiagnosing if you're only screening with TSH? What are those situations? Conditions in which TSH alone may be misleading. So the first is when thyrotoxicosis is being treated, and this is a very familiar and common situation. Thyrotoxicosis is being treated and TSH may remain suppressed even when the T3, T4 concentrations have normalized. So this does not mean that you go on increasing the dose of whatever treatment you are administering as an antithyroid drug, but you need to wait. You need to give it time for the TSH to come up. There may be TSH assay interference. So sometimes when it does not correspond with the clinical picture, whether it's a low or a high TSH, then you need to consider the laboratory artifacts. Non-thyroid illness, I've already talked about. Central hypothyroidism, this is very important. Be very careful about this, because the hypothalamic pituitary disorders may be associated with a low TRH or a low TSH, and hence the TSH will be misleading because it may be within the low normal range, or and the T3, T4 may be quite low if you were to do that. TSH secreting pituitary adenomas, again, the TSH levels may be modest, and unless you do a T3, T4 and see that there is incongruence in the feedback, you will not pick this up. Resistance to thyroid hormone, we've already talked about. So if there is tissue resistance, the TSH level will go up, and you actually think that there is hypothyroidism, whereas you have one of the thyroid hormone resistance syndromes. There are rare disorders of thyroid hormone transport or metabolism, again, which may be misdiagnosed if you only do screen with the TSH. So now let's look at the different thyroid function patterns and see what their etiology is. Basically, there are 7 major patterns that we need to account for. One of them is the normal pattern with the normal feedback, and the rest are various permutations of it. And there are several conditions and circumstances in which each one of them can arise. So I'll just quickly try and go through those in the next few minutes. When you see these tests, you need to, and you see tests that are not normal, you need to initiate further investigations, and the further investigations will depend on how you analyze these tests. So the choice of further laboratory tests or radiological tests, or whether you need to pursue genetic tests in the case of thyroid hormone resistance, or you need to focus to confirm or exclude other specific diagnoses. So this is the normal pattern. You have FT4 and FT3 within the normal range, and the TSH is also normal. So this is normal. Let's see the first pattern. The first pattern is a free T4 and T3, which are low, but the TSH is normal or it is low. So there is an incongruous combination here. This can happen with non-thyroid illness, as I talked about. It can happen when there is There are also rarely cases of isolated TSH deficiency with no other deficiency of pituitary hormones or no other structural lesion in the pituitary. So be mindful of that also. And then there is a lab artifact. What is the next pattern? Your free T4 and T3 are normal, but your TSH here in this case is low. So here you had a low FT3 and FT4 and a normal or low TSH, and here you have a normal FT3 and FT4, and you have a suppressed TSH. So this may be subclinical hyperthyroidism, increased secretion of thyroid hormone. And like I told you, every individual has a very narrow set point, and the pituitary begins to recognize overproduction or underproduction even before we see it in the T3, T4 levels. This may be, like I already said, recent treatment for hyperthyroidism. The TSH is yet to come up, even though the FT4 and FT3 have normalized, and drug interference, assay interference, and non-thyroid illness can give you this pattern as well. The next pattern is a free T3 and T4, which is raised, and a TSH, which is suppressed. Basically, this is behaving quite easily, and that is the classical pattern of hyperthyroidism. And all the causes of excess of thyroid hormone fit into this category. So I'm not going to go into any of those details. What is the next pattern? So the next pattern is FT4 and FT3 that are elevated, and TSH is either normal or also raised. So when you see this kind of incongruence, always assay interference. And this is another rare familial disorder, again, which is a dysalbuminemic hyperthyroxininemia, in which it is familial, it's picked up in children with hypotonia, and there is psychomotor development delay and spasticity in old age, and all the, it goes by a fancy syndrome name. So it gives you a kind of odd resistance pattern in the brain. LT4 therapy with poor compliance. This is an interesting group, and this is because this patient sometimes takes thyroxine and sometimes doesn't. And when it comes time to see the doctor, they take a bit more. So that you may find that the free T4 and T3 levels are high, but the TSH is, either normal and we often forget that this might be happening. Then drugs and non-thyroid illness, the neonatal period may give you this kind of pattern, which is normal for that period of life. So we need to factor that in. There may be a pituitary secreting, TSH secreting pituitary adenoma, or there may be thyroid hormone resistance. Free T4 and free T3 are normal in this pattern, but the TSH is raised. So this may be subclinical hypothyroidism, which we again see quite a lot of, the same explanation as I gave you before for subclinical hyperthyroidism. This pattern you may also see with poor compliance, where FT4 and FT3 are normal, but TSH still takes a while to come down. Or it may also indicate some malabsorption, even if the patient is taking regularly. So we need to go into all the causes of malabsorption. And drugs, assay interference, non-thyroid illness, and TSH resistance can also be a part of this. And the last pattern I'm showing you is the classical hypothyroidism, which is a low FT4 and FT3 with a raised TSH. No difficulties there. All the causes of decreased thyroid hormone production are enumerated here. Let's briefly look into anomalous TFTs on LT4 therapy. So I've already kind of covered many of these things, but if your TSH level is normal and the FT4 is mildly raised, this may be a normal physiological variant. So this may be related to a slow kind of deiodination or something, and here FT3 levels are normal. So these are euthyroid people, and just don't jump into some kind of action if you see this pattern. I've discussed this pattern with you. The reasons would be maladministration, so taking with food and stuff, and malabsorption syndromes, and thyroid hormone metabolism or excretion being affected either by drugs or by hepatic metabolism or urinary thyroid hormone loss. And increased thyroid hormone binding capacity, like estrogen therapy when people are oral contraceptive pills and stuff, will change it, and if they're on thyroxine. So factor all of those things in before you jump to any conclusions. Unexpected change in thyroxine dosage to maintain euthyroidism. We all know, check the preparation they're taking, and see if the brand has been changed, because not all brands are of equal efficacy. So the instruction should be to, as far as possible, not change brands. But we all know that from time to time, the situation is a little better now. But previously, particularly, some brands would disappear for a long time, and then patients had no option but to shift brands. So if there is a TSH which is raised, which is normal, FT4, always be consider this, and you need to consult the lab to see if this can be sorted out. Persistent TSH elevation with low, raised, or normal FT4 despite high LT4 dosage, compliance. So when you need higher than normal dose of levothyroxine to normalize the TSH, always be wary of thyroid hormone resistance. And this is a situation where you may need to go into the possibility of thyroid hormone resistance. And because the LT4 is raised, the LT4 requirement is raised, people, TSH is suppressed, they think that this may be toxicosis. And this is a situation which is often seen when thyroid hormone resistance is treated, misdiagnosed as thyrotoxicosis and treated with ablation, and then they become hypothyroid. And now you have a complex situation where hypothyroidism is being treated along with a patient who also has thyroid hormone beta receptor mutation. So this is a particularly difficult situation. Be very wary of it. I just want to show you some diagrams to illustrate the assay interference in one case, and there are other methodologies that the lab can use to get past this if we suspect this. So basically, immunoradiometric two-side sandwich format is used, in which there is a capture antibody and there is a detection antibody. And they are detected against, the antibodies are made against different epitopes of TSH. So therefore, this is TSH, this is the detection antibody, and this is the capture antibody. And this is how, the capture antibody is stabilized on a solid medium, and then the TSH is kind of measured. The analyte, that is the TSH, basically acting as a bridge between the two in the sandwich. The possibilities here are then that you may have a cross-linking antibody that kind of links the two, the capture and the detection antibody, without the TSH being there, and kind of overreads the TSH. This is a positive interference. Or you may have this situation where there is another antibody that comes and blocks the capture antibody. So TSH is hanging around, but it can't be read. The sandwich can't be made. And that will give you a negative interference. Let me just briefly talk about thyroid hormone resistance. And the commonest is thyroid hormone receptor mutation beta. Distinguishing between thyroid hormone resistance, that is the beta mutation, which is the commonest, and a TSHoma can be very challenging. And clinically, it is impossible to differentiate the two. So it's very important that we have both conditions in mind, and sometimes it's very important to keep looking at the tests if they have been done in the previously and what the treatment history has been. So really sit with all your guards up to see what's going on in this situation. The estimated incidence of thyroid receptor beta mutation is not that uncommon either. And TSHomas are the rarest of all pituitary tumors, less than 2%. Having said that, now that there is increased awareness, there is highly sensitive TSH assays available, the diagnosis of TSHoma has increased 2 to 3-fold. So the more we know, the more we suspect, the more we are probably going to pick them up. The estimated prevalence of TSHoma, however, is 1 case in a million. So they can be overlapping clinical phenotypes, and hence we say that differentiating it clinically is going to be very difficult, unless you have features of a pituitary macroadenoma, which kind of straight away directs you in that area. And the clinical picture may be asymptomatic and just an abnormal thyroid function test, or to avert manifestations of thyrotoxicosis. What about the beta mutation? So how do you differentiate a TSHoma from a beta mutation, a receptor mutation? Here, T4, T3, and TSH, the pattern that we usually see is raised TSH, or with normal or raised FT3 and FT4. But there are other causes of persistently raised TSH, and I've already talked about that. Following thyroid ablation, suspecting thyrotoxicosis wrongly, in a patient with this mutation, reversible thyrotroph hypoplasia and pituitary enlargement may occur, a bit like the Nelson syndrome that we talked about, that we all know about. So alpha subunit, we cannot unfortunately measure this. Here, increased pituitary glycoprotein hormone alpha subunit is produced by TSHomas, and the alpha subunit, even if it is normal, but if you do, there is an increased ASU and TSH ratio of more than 1. And that is very suspicious of a TSH producing microadenoma. Sex hormone binding globulin is a peripheral tissue marker of TH, but it is hormone action, but it is very limited in its utility because it's not very specific. T3 suppression test is of limited values, particularly in younger patients, and we don't have T3 here anyway. So TSH response to IV TRH, this is a very useful test. Again, we don't have TRH here. It's very expensive, but for some patients it can be managed. So what you do is you inject 200 micrograms IV, sampling at 20 and 60 minutes post-injection. Relatively easy and safe test, and it has a good discriminatory power. So less than 1.5-fold increase in TSH suggests TSHoma in 80 to 90% of the cases. And more than 5-fold increase in TSH, this shows an exuberant TSH response, and this is indicative of mutation in the beta receptor gene. Pituitary imaging, of course, it will be very helpful, and nowadays with the new scanners with very good resolutions, very, very small tumors can be picked up, and that has made life very easy also. The somatostatin receptor ligand therapy, octreotide or lanreotide, they can also be used. Most TSHomas, about 90%, there will be a significant decrease or normalization of FT4 and FT3 after a 2-month trial of these drugs. Whereas in the beta gene mutation, no significant change in FT4 and FT3 can be seen. And of course, there can be genetic tests, which are not available here, but can be done, can be arranged. Approximately 80% are dominantly inherited. Abnormal TFTs in the first degree relatives will strongly suggest resistance to thyroid hormone. And the beta gene sequencing confirms the diagnosis in 85% of the cases, but in 15% of the cases, associated with are not associated with the identifiable genes mutations. So there must be other mutations that we don't know of at the moment. So I'm not going to go into the details of drugs. Suffice it to say that there are many drugs that interfere with thyroid function tests, and you need to be cognizant of that. And in this category, the TKI inhibitors, more and more of them being used for anti-cancer therapy, the endocrine impact of it needs to be taken into consideration. And we as endocrinologists must be aware of it. So, familiarize yourself with the drug changes, with various drugs you're using. And every time you see an incongruous thyroid function test, ask yourself or ask the patient what are the drugs on board. So although I'm talking about thyroid function tests, it is sometimes very, very important to do other tests. Like I said, how you read the thyroid function test dictates what next steps you're going to take. So radioactive iodine or technetium imaging of the thyroid is very helpful in differentiating some of the causes of increased T3 and T4 and localization of thyroid and the presence or the absence of thyroid. We always have to make sure that we have excluded the contraindications before we go ahead with it. And of course, the steps that have to be taken after the radioactive iodine has been administered. And I'm not going to go into the details of thyroid ultrasound imaging, which is now crucial in the case of an enlarged thyroid, and particularly in the case of a nodule, but it may be of help in cases of discordant thyroid function tests along with the radioisotope imaging. So in summary, when we're looking at discordant results, the step one is to reevaluate clinical history and consider the age of the patient. I told you the neonatal period pattern and the elderly results. We even see it on our thyroid function reports. We've discussed the pregnancy changes, so make sure pregnancy is being excluded. And when a patient is on thyroxine therapy, consider all the things that can produce an incongruous report. And sometimes patients can be very deceptive. And you can do, when you really suspect it and there's no cause for a discordant result, then you can do, apart from the usual malabsorption test, you can do a loading test, and there are protocols for that to confirm non-compliance. The confounding drugs I've talked about and non-thyroid illness. So this is the first step. You need to reevaluate the clinical history. And the second step is to reassess the thyroid status in the light of what you come up with, reconsidering all this. So then you need to see, is this patient hypothyroid, euthyroid, or hyperthyroid? Once you've done that, then you decide which thyroid function test is most likely to be discordant. So, then you need to pursue according to that. Exclude thyroid hormone or TSH assay interference before you run into a whole lot of other expensive tests. And in this case, you need to consult with the lab you're using and see what alternative tests they can do to give you a more reliable or believable result. And lastly, if nothing else comes up, then you need to investigate for rare genetic or acquired disorders of HPT function. And here you need to really refer these patients. With that, I would like to conclude, and thank you very much for listening to me patiently. Actually, we've covered a lot of grounds in this, and the last take-home messages, when you're confronted with a patient in whom usually people do their tests themselves now, or somebody's done it, it's the wrong set of tests, and you're sitting with the thyroid function test and you're scratching your head, on how to go about it now. So be very careful in ordering a thyroid function test. Think in your mind what kind of thyroid dysfunction you're suspecting and order the appropriate test, and then think very carefully when you get it again. And at the end of the day, make sure that you always go back to the patient and see if this test and your analysis of this thyroid function result matches the clinical picture of the patient. So with that, I will end and thank you very much.
Thank you, Madam, for this concise, precise, informative lecture. And I think now I will proceed to the post-lecture BCQs, and then we'll ask a few questions. They are in the chat box from Madam. Zareen, can you please start the post?
Yes, Nida. I will suggest to speak a bit louder. I'm not able to hear clearly. I don't know about other participants.
Okay, can you hear me now?
Yes, better now.
Thank you, Madam,
So,
for the very informative, very precise, concise lecture. And now we will proceed to the post MCQs, post BCQs, post lecture BCQs. I think Dr. Zareen will elaborate the post lecture BCQs, and then we'll have the question answer session for 5 to 7 minutes with Madam. I have few questions in my chat box here, but I think we should proceed with the MCQs first, I think. Yes, Dr. Zareen, what do you say?
Yes, I have launched the questions. I hope all the participants, attendees can see the questions again. And so I'm not going to read each question again because I've read it once before. We'll just wait for the participants' response now and check on the timer. So I again encourage all the attendees to kindly participate in the post-lecture poll, which has been shown on the screen now. This is question number 1, and I'm just waiting for the responses, so then I'll start moving. So I think after 2 minutes, I will share the results, because then we have to discuss the questions as well. So, I mean, I'll just share the answers, the 2.
Yes, I think Zareen, you should share the results because.
Okay, I'll just end the poll now. And I'm going to share the results. Nasisa, I don't know if people can see the results, because
Yes, we can.
Madam, all participants and attendees can see the results now.
It's visible, madam. It's visible on the screen. It's okay.
Okay. So for the first question, 89% of the participants have opted for gestational thyrotoxicosis, which is correct. And okay, for this one, the second question, which is again correct. For the third question, which of the following form is the most active form? 53% participants have opted for free T3, which is correct answer now. Again, in option question number 4, 16% have actually, opted for subclinical hyperthyroidism. So this was a tricky question, and I assume, I hope we could, disintegrate the participants' activity and see who are the people who have opted for this. But the correct answer here is the thyroid hormone resistance. And this is the scenario which Madam have explained in TSH beta receptor related thyroid hormone resistance. So detailed explanation on that. I don't think any of the fellows would be able to read that during their fellowship the way Madam has explained. So this is obviously a tricky question. Let's move on. And the last question here is, the answer is drug-induced subclinical hypothyroidism, which is again the correct answer. So I think 90% correction is quite impressive.
I think I should ask you relevant questions with Madam. The first question, ma'am, is any indication? Is there any indication to advise the patient for fasting TSH, or we can do in the random also?
So it is better if it is done in a fasting state and in the morning, because there are diurnal variations in the thyroid hormone TSH levels or thyroid hormone levels. So much more than fasting, I think the timing of the day is important. So we should advise all patients to do it in the morning, and we don't need a prolonged fasting or anything, just give a sample before eating, that's all. But if they have eaten, I don't think it has a great difference to the thyroid function.
If any patient after RAI ablation on thyroxine, but the TSH goes up despite of optimal thyroxine therapy.
So to me, this looks like a patient that I was describing. This was actually thyroid hormone receptor beta mutation and resistance, and patients had clinical features of thyrotoxicosis, and they have raised FT3 and FT4, but they're, this is not recognized that this is the raised TSH is not registered, and they're ablated. And once you ablate them, the thyroid is also gone, and you're replacing, but that there is a resistance to the action and the cellular. So the resistance syndromes is something that you have to think about when you're ablating the thyroid in a thyrotoxic patient with incongruous results. And that resistance, like I explained, could be at many different levels.
I think this is it. I don't think so.
There can also be the possibility that जो आप वो thyroxine replacement कर रहे हैं, उसको, how is the patient taking it? That is the more common things, look at, what are the other drugs they're taking? Are they taking all the other drugs with that? Is there a possibility of malabsorption? All of those things have to be taken into consideration.
Thank you very much, madam. I think this is it for today. And I would like, in the end, if Dr. Akhtar is with us, our Director of NIDE and our Head of Department of Endocrinology, DUHS, NIDE. Sir, if you are there, can you please conclude? We need some concluding remarks from you. I'm not able to see right. Yes, I think he's here. He's still here. Zareen, are you sure if he is here or not?
Yes, I can see him in the panelist list, but I'm not sure if he is listening to us. So we can take remarks from Dr. Ahsan and then I can comment. Dr. Ahsan, can you give some comments, please?
We can't hear you, Dr. Ahsan. Please unmute yourself.
Okay, thank you very much, madam, for a very comprehensive and enlightening lecture. And it has been always a pleasure to listen to you. And thank you all the participants. It was very enriched and enlightening lecture. And I hope we'll be able to listen to you again and again, inshallah. That is all from myself. And see you again, inshallah. Thank you very much.
Thank you, Dr. Ahsan. Before over to Dr.
Okay.
Zareen.
Okay, Professor Akhtar has unmuted himself. Sir, please give your comments.
Hello, assalamu alaikum. Hello, Assalamu alaikum. Can you hear me?
Walaikum assalam.
Can you
Yes, sir,
hear me?
please. जी जी सर बिल्कुल आपकी आवाज आ रही है.
I would like to say thank you to our worthy professor, Professor Tasnim, for such a nice and excellent talk today. And hopefully it will improve our clinical practice and help those fellows to take in the exams. Thank you very much, Madam, for your time which you spared from your busy schedule today and decided to participate this talk. And I take this opportunity to say thank you to all our worthy consultants and professors who have consented to be the part of this crash course. And also I'm thankful to my all faculty members, especially Dr. Zarin, for organizing today's lecture. And lastly, I would like to request to all the participants please to give us feedback to improve this course. There's always room of improvement. So to make it more fruitful for them and for us, please, and don't forget to give us feedback in terms of time management, in terms of selection of day and the content as well, because we cannot cover all the topics. We have tried our best. So we will be anxiously waiting for your feedback to improve the course and to make it more fruitful for all of us. Thank you so much.
There is a feedback form which we will going to email you and kindly reply and give your feedback. Zareen, can you please give your comments and then we'll end the lecture, end the program.
We also have Dr. Umar on here. Dr. Umar, would you like to say something?
Thank you, Dr. Zareen. Very elaborated lecture by Professor Tasnim Ahsan. Are you hearing me?
जी 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 बिल्कुल डॉक्टर उमर.
Yes, we can hear you.
मैडम ने समझ लें समंदर को कूजे में फिट कर दिया. बहुत ही आपने बड़ा टॉपिक दिया था उनको, थायराइड डिसऑर्डर. So she has, as usual, she is Professor Eminent, delivered very nicely, and we we will get help from this. And thank you all of you, especially our director, Akhtar Ali Baloch, Dr. Zain, who has arranged this lecture, this course for us. Very good course for fellow, postgraduate and fellow. Thank you all.
Thank you. Okay, now I'll give my comments. I mean, I don't have to say anything further after what my faculty has already said, and I will just say many thanks, and I'm really grateful to Professor Tasnim Ahsan for sparing her valuable time on a Sunday. Thank you so much, madam. We look forward to working this way with you again in the future. Over to you, Nida. Thank you.
Thank you very much, and we'll meet next week, inshallah, with another program. Thank you very much, Barrett Hodgson, madam, sir, our faculty. Thank you very much. Allah Hafiz.
Hafiz, thank you very much.